Thanks for listening to my talk today, Social Determinants, Risks, and Needs, Implications for Promoting Health Equity and Inclusion. I want to start today's conversation by exploring how we get to know the people for whom we are caring. I recall in nursing school hearing repeatedly that we see only a glimpse of our patients' real lives, and only that is when they are not themselves. So here are some pictures and facts about me. But what do you really know about how well I could manage a serious illness? What support would I have? What financial resources? What does the rest of my life context look like? And how could that support my health? And so who are they? These are pictures of patients I had when working as a clinician and researcher focused on diabetes care. And these early observations, I noticed that despite knowing many of my patients had limited literacy skills that placed them at risk of poor outcomes, many did quite well managing complex conditions. But overall, I knew that limited health literacy placed people at risk for poor outcomes. My clinical hunch was that this often had to do with who else was involved in their care and the other social circumstances of their daily lives. So, my research has been grounded in these three questions. How do social resources affect diabetes or disease self management and contribute to health disparities? How can health systems feasibly and effectively respond to social circumstances? And how do we best educate clinicians to respond to social circumstances? But we often face challenges in doing this work because instruments assessing social support often could not be completed by those with limited literacy and did not ask questions that gave us usable information about patients' lives. I didn't feel like we got to really what mattered that I could use to guide people's care. So, in routine clinical care, we're often left with the lowest common denominator of social context assessment. We do not know what to do with the assessments once we have them, and we go without a firm understanding of how to best intervene. So, why do we care? Hint, it all starts with health disparities. Here is a visual of why we need to care. Salt Lake City downtown life expectancy is 75 years, where the population is more heterogeneous compared to the more affluent Avenues neighborhood, just right up the road, where it's nearly 86 years. This is a dramatic example of health disparities in our community. And we now have important clues about the sources of these health disparities. There are many graphics that show different percentages, but there is overwhelming evidence that social conditions, circumstances, environment, and I would argue behavior and medical care is part of those social circumstances as well, is all responsible for the majority of health outcomes. Now, of course, biology and genetics are important, but the vast majority of health outcomes, and thus disparities in those health outcomes, are byproducts of social factors. And here's a visual from the National Institute of Minority Health and Health Disparities that shows how they break down the complex factors we now know contribute to health disparities for different populations. Here it clearly shows the complexity of what are primarily social factors at play. So why we care is that here is to achieve health equity, we need to address health disparities. So then, what do we do about all this? Hint, we organize our thinking with the use of some key terms. And the first term is social determinants of health. Social determinants of health, or SDOH, are the conditions and the environments where people are born, live, learn, work, play, worship, and age that affect a wide range of health, functioning, and quality of life outcomes and risks. A critically important thing to remember about social determinants is that they can both positively and negatively affect health outcomes. And this is a key thing to remember moving forward when you hear conversations about social determinants of health, because it's often misused as a term. Term 2, social risk factors. Social risk factors are the specific adverse social conditions that are associated with poor health, like social isolation or housing instability. These are factors that negatively affect health outcomes. And term 3, social needs. The need for an individual as a result of social determinants of health for things like food, housing, medicines, help with self-care. They are the specific tangible needs that, if unaddressed, negatively affect health outcomes that are most often assessed in healthcare settings. So let's take stock with an imperfect visual for linking SDOH risks and needs. So again, social determinants is a very broad term that usually aligns with systems level interventions. I say usually, not always, but usually. Most of the research in this area is ideologic, and the implication is more about public policy. Think anti-discrimination legislation. Social risks get a little more concrete and actionable, perhaps variable high school graduation rates in a community that then can get to the individual level with a variable called education. And at the individual level is where we, again, generally speaking, move more toward interventions such as social work outreach or screening. But this is really hard work when undertaking interventions to address social determinants or needs. So we are gradually building models that may help understand how social determinants of health data can be used across the clinical spectrum. Here's one example of many, but it's a useful example of how to help frame frame our thinking. In this, you can see it aligns well with the yellow one I gave 2 slides ago. But here on the left, we start at the individual or more reductionist level and move to the societal level and the more expansionist level on the right. So, starting on the left at the individual level, we use risk assessment in clinical decisions. The idea is to screen for things like social needs, food, housing, and security, things like that, and connect with resources. Here are examples of 2 commonly used screening tools, the CMS Accountable Health Communities tool and the Prepare. We also use yet another in our work at UHealth called the Sincere Screening. And this slide, and granted these are from 2019, but it shows we have a long way to go to even screen for social needs, much less address them in our clinical settings. The second strategy in that framework that I just offered is performance assessment. Here's an example from a 2019 HSR paper that talks about this, adjusting for social risk factors impacts performance and penalties in the hospital readmissions reductionist program. And really what this tells us in a nutshell is that risk adjustment and performance assessment is a way to account for the fact that certain places, by the nature of what they do and where they are, treat patient populations with more risks and needs. That complicates system improvement or the processes in the middle, and that needs to be understood as a central focus and accounted for when trying to address social determinants. We really need to understand how certain healthcare systems, I wouldn't say disadvantage because that's the wrong word, but it's difficult to move the needle in terms of outcomes, and we need to understand how different populations affect our healthcare system. And here, person-focused interventions. Here's an RCT looking at the impact of a CHW being placed in care on a post-discharge outcomes in a targeted patient population in Philadelphia, where community health workers, social workers, and case managers offered comprehensive care. And this is a very common model of addressing person-focused interventions. But something to note here in these person-centered interventions that they need to use person-centered metrics for evaluation. And this is a key emphasis in this research being done now. How do we get to a good outcome measure in interventions that actually are trying to address social needs? Is it readmission? Is it reduced costs? Or is it something else like engagement, the quality of communication and activation for patients with social needs? So this is a key question being tackled right now. And the final interventions in that model is that they impact a whole population. A recent high-profile example you may recall is how the elevated blood levels in children in the community of Flint led to policy changes at the local and state level. This is another example would be looking at access to care in rural populations, for instance, and public health measures to address that. So now I'm going to take a break, and I want to briefly talk about lessons we've learned from our own research at UHealth. Our interventions focus on social needs screening. We developed a social needs screener for food, housing, transportation, things like that. Patients are screened in the ED, and then United Way's 211 service contacts patients within 48 hours of discharge to give community service referrals. And we know that patients receive an average of 5 service referrals for 46 unique community resource providers, community clinics, prescription drug discounts, charities covering costs of medical tests, housing, food, utilities, children's charities, and transportation services. And then we try to learn from all this, from our screening data, from the 211 outreach data, and then we pull data from Epic's Enterprise Data Warehouse. And we've documented a lot of need in our UHealth ED. Between 40 and 60% of ED patients screened indicate needs, and 60% of whom wish referral to 211. And I say that range between 40 and 60%. It depends on the population and the time of screening. And what we've learned, we have few to no technical barriers for staff, 211, or the patients in doing this. We do this with very simple technology. But staff and patient qualitative work identifies screening and referral barriers rooted in stigma, privacy concerns, and a desire for sincere connections. And an important implication of screening in terms of equity is that unless we find ways of doing this better, we won't reach the majority of patients who have needs and realize population health benefit from addressing social determinants of health. So we continue. Right now, we are conducting a 4-year study to examine whether community service use improves health outcomes and whether thoughtful connections and collaborative goal setting overcomes barriers to community service use. So this is all to be continued, where we're really trying to improve the outreach of our intervention. And our second study about social needs that's going on at UHealth is in the inpatient setting as part of a hospital discharge process. And in this study, patients' social needs and supportive resources are assessed and communicated through EPIC displays as part of discharge planning. We are examining service and unit level changes in patient readiness for hospital discharge, post-discharge coping, and readmissions. A particular focus of this work is on the clinical team itself, on how well they communicate patient-reported outcomes and how they communicate patients' social information. So far, what we've learned is that discharge team members' understanding of social needs is associated with patient-reported outcomes. Social needs assessments contribute to decisions about discharge with home health or to skilled nursing, even when controlling for demographics, insurance, and acuity. And social support is perhaps the most important social need to assess. And overall, there's a critical need to make social information transparent during hospital discharge and transitions to follow-up care. A patient is more than their discharge summary. As we know, how do we know about these people and what their circumstances are? So, wrapping up, we have some takeaways here. Screening for social determinants during clinical encounters remains controversial. And there's debate about whose job it is, whether it distracts from other medical care, and clinicians do not feel very confident in their capacity to address social risks or needs. But patients know it's important. They know our limitations to address all their needs, and they want it to be done well, not just a list of things that you're checking off in your daily encounter. And finally, patients want screening to be accompanied with concern, care, and sincerity. There are important implications for inclusion here, as social inclusion is marked by all groups of people feeling included and valued within their society or community. So, if we want to groundwork in social determinants, we need to ground our work efforts in these tenets if we want to address health equity and address inclusion. We want to include patient-centered metrics. We want to conduct universal screening to limit bias, so we're not selecting people based off of appearance or other demographic characteristics. We want to consider health communication needs, literacy, language, culture. We want to ensure privacy when exchanging data, link to service providers with clear referral processes, and we want to address patient receptivities and barriers. Thank you for listening to this work, and I hope this gives you some good ideas about how to address health equity and foster inclusion in social determinants of health.